Welcome back to The Directors, a special segment of the Cancer Letter podcast sponsored by the American Society of Clinical Oncology. This time, Roy Herbst, director of Dartmouth Cancer Center, and David Gius, director of the University of Cincinnati Cancer Center, talk about their first few weeks and the top jobs at their institutions. The job of director comes with an opportunity to imbue the center's program with a new energy and explore new directions in science. Herbst and Gius are physician scientists. Herbst is a medical oncologist who specializes in lung cancer. Gius is an expert in breast and lung radiation oncology. Herbst is also the Ensign Professor Emeritus of Medicine at Yale Cancer Center and Yale School of Medicine. Gius is also the former Zell Family Scholar Professor, the Director of the Women's Cancer Research Program, and Vice Chair of Translational Research at Northwestern University's Feinberg School of Medicine in the Department of Radiation Oncology and Pharmacology. And with that, let's get started.
Well, welcome to The Directors, a podcast of the Cancer Letter. With us today, we have two of the newest Cancer Center directors. We have David Gius of the University of Cincinnati Cancer Center and Roy Herbst, the director of Dartmouth Cancer Center. And the first question is always the same, which is, what's keeping you up at night as you run your cancer centers? Who wants to start?
David, do you, or I'm happy to?
All right. Well, since Roy has just started, why don't we have Roy start?
Well, Paul, thanks for having us here today. This is my third week here at Dartmouth. And it's just been a fantastic start. We started with our Proudy event, which is a big fundraiser, and I've been working ever since. So what's keeping me up at night? Well, I'm so busy, I'm pretty tired at night because, I'm trying to just listen and learn the clinical care side of the operation, the research, I'm meeting people. But I guess, it's the responsibility I now have, to lead this center and take care of a catchment group of patients in New Hampshire and Vermont, to make sure that our team are supported. It's of course, a difficult time for funding. And actually later today, I'll be leading the Scientific Policy and Government Affairs call for the AACR. And we're going to talk about what's happening at the OMB and with grant funding. But really, it's just the tasks at hand, the importance of fighting cancer, to have impact in this rural community, and bringing things from lab to clinic. So I understand my responsibility. I'm busier than I've ever been before, but this is what I've been looking for my entire career. It's a capstone for me, and I'm really excited to be here.
David?
Yeah, and Roy said many of the things I would have said as well. Right, like him, getting this job is something I've always aspired to, and I agree, it's something to cap your career. And also, there's a lot of responsibility, and it's my fourth week, so there's a lot to do. But to talk about what's keeping me up at night academically is I feel like medicine, and especially cancer care or cancer precision care, is really at the interface of new technology. Right, machine learning, big data, AI-generated ways of managing data, interrogating data, managing our clinics. And I feel like it's moving very quickly. And I think that academic medicine and cancer centers, we need to be at the forefront of this. We need to be proactive, right, in bringing these technologies in and making sure they're implemented in a way that benefits our patients, benefits our cancer center, benefits our community. And I was watching a podcast yesterday, and an expert in this field says, you can have a plan for next year, but by the time we get to next year, you'll probably have to have a new one. So I think that keeps me up. We need to be thoughtful, flexible, and proactive for what is going to be obviously something that's going to change the way we treat our patients and run our cancer centers.
Mm-hmm. Where are your institutions right now in terms of the NCI grants? David, you're a few years away from applying, and I think Roy, you just got funded.
About a little more than a year ago, the team got funded. Yeah, I'm very fortunate. I pick up this job from Steve Leach, who did 7+ years as director, 2 renewals, very successful, and then became the dean. And then Konstantin Dragnev, who actually is a colleague and friend. We've worked together on the lung map trials and so forth, has been running the team for about a year. So we have about 2.5 years until we're going to submit. And, of course, that's something on everyone's mind. I've been at MD Anderson and Yale, so I'm pretty familiar with the grant. But I'm trying to even go above the grant here, and think about, just as David was saying, it's the impact. How are we going to deal with, the new science from the lab to the clinic, artificial intelligence, and how we're going to use that for precision prevention, screening, and new drug development. How are we going to find new drugs for resistance? And so, but yeah, the grant is something. We have a meeting later today, and it does give a format. Actually, it's for me as the new director to learn what's going on. So I'm glad we have that in place.
Yeah, and for my cancer center, we're hoping to go up in 2.5 years to get what they call designate status or clinical cancer center status. So one of the reasons I was recruited here was the idea to kind of reorganize and lead the cancer center to NCI designate status. So a great deal of my time is spent, is moving the chess board pieces around, just reorganizing the cancer center, putting it in a position so that we can write a grant, right, that will be favorably reviewed from the NCI. So our goals are a little different than someone who's already at a comprehensive cancer center like Roy, right? We're hoping to get just designate status, and I'll just tell you, almost every day is spent on that.
What's your emphasis, I guess, for both of you? How are your institutions going to look in roughly the same time, 2.5 years from now?
Right. Well, here, we can always do better and have more impact. Touch more lives. I can tell you that the cancer focus here is really strong, and the culture is strong. The thing that I'm loving is that there's a community that really supports the center. We're a small state. We're the only cancer center in this state, one of 3 cancer centers in New England. But this town of Hanover has 25,000 people, and perhaps a few more in the summer and the winter, during the holiday seasons. But we have a big catchment area because it's rural. I'm learning all about these rural scores, and so we have an important role. And I think in 2.5 years' time, I'd like to improve the translation here. I'd like to see more of the amazing science that's being done here at Dartmouth Health, Dartmouth College. I'd like to take that forward. There's an amazing history here, Paul. I didn't realize this until I started visiting here, that Medarex, Medarex, where nivolumab came from, the DAR is Dartmouth. So there's a great history of drug discovery, even though we're small. So I'd really like to translate and do more clinical trials, more community outreach, take advantage of some of the engineering advances here, surgical advances. So I have a lot to learn, but the team is, I'm just one member of an already amazing team. So I'm humbled to be here, and 2.5 years we'll have a good grant and hopefully even more impact and advances that help our patients.
And I think that's true too. Cincinnati is a little bit more diverse catchment area. We have large urban area where our catchment area is underserved for medical care. We have Northern Kentucky, which is its own kind of unique cancer care population. We have kind of north of Cincinnati, but Southern Ohio, which is agriculture. And that's kind of a unique patient population. And of course, east of us, we have the Appalachian Mountains, and that's a unique patient population. So, I feel like the Cancer Center has kind of 2 lanes that are driving parallel to each other. There's the one side where we need to improve and continue to give superlative care to our cancer patients. And of course, I think that's a critical part of being an NCI designation, that is improving the outcomes for our patients members of our community who've been diagnosed with cancer. But then, of course, there's the academic side too that Roy was talking about. We want to translate from the bench to the bedside. We want to do drug discovery. We want to use AI as a way of interrogating how to use the new drugs that we are discovering and drugs that other people are using, and the best way to do clinical trials. We need to improve the way we put patients on clinical trials. So there's a lot to do, right? And I think, as I was saying earlier, as technology is expanding so fast, as cancer centers, we're going to use that technology to improve how we address the academic mission and how we treat our patients.
Right. You said something interesting that struck me, David, the Appalachian Mountains. So I've got the Appalachian Trail running right through town here. So we have to collaborate and all work together,
Yeah, I agree. I'll tell you, when I was at the large cancer meeting, American Association for Cancer Research meeting, I got to go to my first meeting with all the other cancer center directors. And I was so pleased how welcoming and collegial everyone in that group was, including Roy. And I really do feel like there's a sense of community among the cancer center directors and a sense of purpose.
Yeah, I feel the same way. You and I have met a few times over the years, and I look at my EAB, and half of the people I've worked with in the past that I'm inheriting, and added a few more people. But we really have to collaborate. And one of the things, since we're both at smaller centers, we have amazing science, we have unique patient populations, but we should build grants together and projects, especially in this era of big data, real world data, AI, and find ways to work together. I'm excited, Paul, about I-91, which is the straight shot to where I used to live, about 2 hours and 45 minutes. Years ago, Mark Israel, when I was at Yale, and he was the chair of our EAB, used to say, let's meet halfway. And I tried to do it, and maybe I should have done more. But now I'm really excited about, let's work with centers, other cancer centers, do trials together, take our, and understand mechanistic studies, build PO1s and multi-PI grants. And that's something that I'm very tuned into, both internally but externally, and really doing what's best for patients, taking the best therapies from all over the country and world.
Mm-hmm. Mm-hmm. Yeah, both of you mentioned data science. What are your thoughts on how it's sort of a part of your future or near future?
Well, we have a data sciences department. And one of my, as a new cancer center director, I'm sure Roy is as well, we get the opportunity to put forth new initiatives. And one of the initiatives we're doing here is a data oncology health sciences team or center. And we're trying to build the infrastructure here, right, so that we can use, the latest technology to interrogate, clinical data, basic science data, clinical trial data as a way to move forward the center. And just one example would be we're starting up a survivorship program here, both for children with malignancies as they transition to adults and adults as well. And we're using that data sciences oncology team, right, as kind of the foundation of how we're going to interrogate how our patients in their survivorship programs are doing. And one of the small changes the NCI has made for cancer centers, they're putting a larger emphasis on prevention. And prevention covers a lot of ground, but one of the things we're interested in here is prevention of toxicity. And we feel that that's a real opportunity to use big data, right, and AI-driven algorithms to, try to identify those survivors who are more likely to have long-term toxicity and side effects from therapy and intervening sooner. So the idea of prevention in that context is early intervention to prevent the long-term side effects of therapy. So we're trying to use, that's just one example of several. We're trying to use the new data sciences and the new technology to enhance, right, what we can do in the center. And I don't know the exact number, but I mean, the number of survivors is only going up. So our survivorship programs are going to have to expand as our patient populations expand with them.
Yeah, I've seen the same thing here. There's precision prevention, especially given we're living in an area with arsenic and radon gas, and they're actually dump sites here. In this area, as you probably know, Paul, from past projects. So precision prevention using AI, and I'm struck there's a very strong AI center, computer science center here at Dartmouth, and many of the alumni are involved. I was yesterday visiting what's called the Magnuson Center for Innovation. So this is over at the engineering school, which is actually working with projects in cancer to develop approaches using new technologies and new data science tools. So I'm going to be very tuned into that and trying to pull that together. Of course, we're using AI in the clinical side as well. This job includes the Cancer Service Line organization, and we're certainly using those tools in the clinic. But I'm excited about what we're going to use for drug discovery, for understanding new protein folding patterns. And the more we can apply that, the better. And that's certainly on the radar. People here at Dartmouth bring their dogs to work.
Oh, really?
It's really, look, I grew up in New York. I spent a lot of years in Houston and back to New Haven, but there are dogs in the hallway here, and and they don't have to be like service dogs. People can bring their dogs to work. So it's a very small, friendly community. I like it. So
I've been to Dartmouth many times. Lovely community, and it's a fabulous cancer center.
Yeah, well, our radiation oncology group, Charles Thomas is here, and he's really been building that up. And actually, I have to go to Manchester in a few weeks, which is about an hour and a half away. We're expanding to sites all over New Hampshire, Vermont. So you'll have to come visit and when I'm here, and I'd love to show you around once I know where to go too.
Yeah, I look forward to that, Roy, very much.
Well, why don't the three of us meet there? Let's say in late August. I'll be there. I might as well make the disclosure. I'm a part-time Vermonter.
Ah.
Yeah.
Well, you're welcome. Well, we've talked. There's a policy institute here, and a health policy, the Dartmouth Institute. I walk down the hall. There's a big picture of C. Everett Koop, on the wall, and so I love that because it is important to translate what we do and develop policy. So there are going to be some forums here, and you're welcome to come, Paul, and maybe you can even show me how to ski in the winter.
Oh, God. I'm more of a cross-country skier these days, although I can go downhill pretty well without hitting too many things or anything. Staying
I'm
upright.
not really a skier, but I'll try some cross-country with you.
Well, let's definitely do that, and absolutely. That's my favorite thing in the world. So can we talk about money? Money from NCI, is it coming in?
Well, we just got our NOAA for our grant a few weeks ago. So, the money's coming in, and I heard about NR1 yesterday. People are still writing grants. I'm only here a few weeks, and one of the best ways I'm meeting people is they want me to write support letters for their grant. One of the things about being in a small state, we have these COBRI grants, and we have several of those that involve cancer, looking at patterns of care and in older populations with cancer. I'm watching the NCI and the NIH money very carefully, but it's going to be a challenging time, and that's why we need to fund both with grants and foundations. Philanthropy. The support of this community is amazing. You covered this in the Cancer Letter a few weeks ago, but we had our Prouty event, which is named for Aubrey Prouty, who was a nurse here about 50 years ago, who died of ovarian cancer. And we had 5,000 participants in this small community, and we raised $12 million. So that's important because I'm going to hopefully use that money in the budget to try to stimulate, programmatic grants and help young investigators and, help our CERTEC program and our COE. So, but yes, that's, you ask what keeps one up at night. That used to keep me up at night at Yale and at MD Anderson as well. But yeah, we have to make sure we fund the operation and also the clinical operation. Let's not forget that all of our centers are supported by the clinical margin, and that's going to be something we have to watch during these times where the regulations are changing and reimbursement is less, and so these are all things that we have to worry about. But that's been the case since I was a fellow 30 years ago at Dana-Farber, and it goes up and down. And I think we'll just have to keep pressing ahead, be innovative, and then prepare for a rainy day with some of this other supports.
Mm-hmm. Yeah, how's the money?
Yeah, I think Roy is right on in that. It's a challenge, right? But he's right. We've both seen it go up and down. As always, the cancer center director at Southwest, who was I got to work with when I was at Vanderbilt, Carlos Arteaga, who's a superlative cancer center director and a great grant writer. He gave me a good advice. He said, if grants are more difficult to get funded, then you should write a better grant. And I do try to follow that advice, and it's good advice. One of the things we do here is I brought in a grant writing team. We have a professional grant writing editor. We also use an outside grant writing editor as well. And I'm sure Roy does this as well, right? Not only do we write letters for our faculty, especially our young faculty, but we help them. We help them write their grants and their manuscripts, and we try to provide support for them. So one of the things we're trying to do in this very competitive environment is try to help our faculty be more competitive. And I agree, like, philanthropy has never been more important than it is today, right? I'm sure this is true at Dartmouth as well. We have faculty who have always had 2 or 3 NIH NCI grants who are struggling right now. And philanthropy is the way to bridge them, right, until they can get their grants funded again. And I have no doubt they will. So I agree, philanthropic support for the Cancer Center is crucial, not just to keep the Cancer Center going, but to do new initiatives, hire new faculty, and all the outreach, as Rory was saying, COE and CERTEC. It's philanthropy that really allows us to support those programs. And much like Dartmouth, Cincinnati has a large community that's very supportive of the Cancer Center. And we're really grateful for all their support and philanthropic help.
Right. I agree with you. I don't know how the lab investigators do it, with salary support the way it is, having to pay postdocs and grad students, if you can find them. It really is a challenging time. But I love the idea of helping people write grants, bringing teams together. 15 years ago when Tom Lynch recruited me to Yale, and I feel very similar here. There weren't that many programmatic grants or spores. And I developed an Office of Translational Research with some grant support where we actually helped bring 2 or 3 investigators together for the multi-R1s, for the spores. And I left there were 3 spores. I'm hoping to do the same thing here. And I'm actually, if you know anyone, send them my way. We're going to hire someone, PhD level, who's going to help with that effort, and we're going to support them. Because I do believe you have to bring people together, you have to lead them, you have to inspire them. And then hopefully a leader will emerge. This is what Al Gilman used to say in the early days of CPRIT. Someone will emerge. It doesn't always happen. You have to help people to work together. But I really am excited that I see all the pieces here. And, being a little smaller, I have to be a player coach. So I'm going to write more grants myself. And we're going to really bring people together to elevate the science and bring it to the patients.
Well, what's really interesting is listening to Tony Latai. He's saying that the numbers are kind of the same in the aggregate numbers, and things are difficult. Center directors are saying, but the numbers of grants coming in, money is coming through. It's slow, but it's coming in. What is actually happening on the ground? What are you seeing? What's not happening rather on the ground?
I feel some of that angst and why it was a little bit more difficult to get grants was the way that they've changed the way they're funding the grants, right? And many of the institutes are what I call front loading some of their grants, where they fund 50% of the grants in the first year. It's unclear to me how much the NCI does that, but certainly the other institutes do that as well. So I feel like, I understand the idea behind front-loading grants, right? It gives the institution more flexibility in the outward years. But I think that has been one of the more difficult things, is adjusting to that. I think that's why you've seen the kind of drop in the pay line that it increasing this year. But I've seen grants funded this year at 11%, 10%. I'm sure Roy has as well. So I think there was a dip the last year and a half, and I feel like it's coming up again. And I'm guardedly optimistic that funding number will increase 1% or 2% in the next year or so. So I think it's just kind of moving around how they were funding things, and now we're in that transition period. And once we come out of that transition period, I'd like to think funding will be somewhat similar to what it was in '24.
Right. There were I heard there were 500,000 letters written, in response to the OMB proposals. People are concerned. The political influence on grants. We don't want them. We want them to be picked based on merit, not based on political sort of considerations. This front loading is a concern as well. These tight pay lines. It's hard, for young investigators. Many can get the K award, but then the first R1, the second R1, I worry about, young people staying in science, and that's a big responsibility. And it has been for me all my career, but now as the director of the center, I really want to make sure that we're able to support people. But the grants are getting funded. It's quite clear the NCI director and the team, want to support things. But, we just need to, if the funding is flat, inflation is high, it's very expensive to run the operation here. It's going to be a challenge. But again, I think what David says is right. We write good grants, we write more grants, and we just keep pushing and then use other sources of funding. The other thing that I think we need to take more advantage of is industry. One of the things that I was very involved with at Yale, and I'm going to try to do here, is industry alliances. Scientific alliances with major pharma. I think in the right setting, I think that could be a good source of funding and a win-win for both groups.
Mm-hmm. Yeah, I think Roy's really right about partnering with industry and pharmaceuticals, and they want to work with academics, right? They have a certain skill set which perhaps we don't, but I still feel like cancer centers and our scientists have skills and knowledge, right, that industry and pharma would like to collaborate with. And yeah, I agree. And they have significant resources, especially to pump into clinical trials, and we should work with them and partner with them. I totally agree.
Right. We talk about IITs, investigator-initiated trials. They're hard, and, to take something all the way from your own lab to the clinic. We have a couple of those things here. And, one of the things we're raising money for is something called our IMPACT program, Integrated Multidisciplinary Program for Advanced Cell and Gene Therapy. So I'm really psyched about that. But what's wrong with partnering with a pharma and bringing their drug in and studying it, even if it's under their IND, as long as the science is being done here, as long as we're getting samples, we're looking at pre and post, and we're understanding mechanism and resistance. So I think a balanced portfolio is something, and a lot of these drugs do come from industry. So I'm hoping to do a little bit of both. One thing I've noticed here at Dartmouth is we're not doing a lot of industry trials. And so I have to make sure that we become a place that's attractive to industry with tight timelines, activation times, better contracting, easy contracting, all things I've done for years. This is part of my job over the last 10, 15 years. So I've been doing this as a consultant on EABs for many years. Now I'm owning it, and I'm looking forward to making it happen.
David, are you doing something similar? What I guess maybe we should put a number on that. How long does it take to get a trial started at Cincinnati and Dartmouth?
Well, of course, it depends on the trial. Investigator-initiated trial takes a little bit longer because you have to go, from the beginning to the end, and there are more steps involved. Industry trials and alliance trials, often those get approved much faster. As Roy was saying, if you're going to work with pharma and industry, they put you on a timeline, right? Often a kind of a tight timeline. So we have, established different ways that those protocols go through our different committees. And it also depends if a trial's already been IRB approved, right? So an industry trial or an alliance trial like SWOG or NRG or something like that just already been approved by an IRB. So, we try to have different paths for how our clinical trials go through the process here for approval. And we try to accelerate, right, trials that have already been approved or have FDA approval or have gone through other IRBs and have been approved. So I think that, as Roy was saying, it's the industry trials that you really have to get approved quickly, right?
Yeah, I'm also not going to give you any absolute numbers. I'm here I'm not here long enough to do it. If you want, at my EAB meeting, which will be sometime in the fall, that's how we attract people up here with the foliage, I will have those numbers. I will tell you, every place I've ever looked at, even where I left, it's always too long. But you need the right trials at the right time, but you got to have them, get them open quickly. One thing I'm very impressed on here, it is funny, a reporter asked me, why you're not doing the lung map trial, and I actually said, Dartmouth was one of the major accruers to the lung map trial, because I do know we're very good here at doing trials through the NCTN. I have to look more at a balanced portfolio of IITs. There are several IITs that I see. We actually fund IITs through our CCSG grant and through our philanthropy, and then of course more industry trials. One thing I plan to do, and again, as the new guy here, I gotta just take some time, go to some meetings, learn. But I have noticed the faculty are very committed to clinical trials. There are unique challenges to building trust in rural populations, getting drugs out there to people that might not even have a card to get in. So we have to bring the trials out to where the patients are.
Yeah, taking our clinical trials into the community, right, and not have every clinical trial based at the cancer center. I know Roy mentioned this. That's something we're also thinking about as well. And it's an extremely imaginative way to kind of change the way we think about clinical trials. And we're trying to do that here too.
Yeah, that's so hard, David. It depends on what you have for your community site. So, when you start a community site, you have generalist oncologists usually. And, my belief is that with time, you want to develop a specialty oncology group, but it's hard to do that when you only have 1, 2, or 3 docs there. So what I've learned through, doing this at Yale, and, I left there, we had 15, 16 sites, you just have to be patient, build up your interactions and your alliances, start to get your disease teams working with doctors in the community, but get people excited that clinical trials are really helping their patients, helping their practice, and slow but steady. But I couldn't agree with you more, especially someone who's rural, someone who doesn't have someone to bring them to the doctor, doesn't have a lot of money, can't even afford parking sometimes. They need to have the trials closer to them. So that's something we definitely need to think about. And then, of course, the whole simpler, more pragmatic trials. Let's do trials in these populations that don't have 80 lab values that need to be done on day 1 and 4 biopsies. Just very simple drug A versus drug A plus B. There's nothing wrong with that, as long as you're getting the best standard of care versus something new to people in different areas of different diverse groups.
Well, maybe we should just even back up a little bit, because what is your relationship with the community groups? Do you own them? What do you do? Is it the same as Yale? And I guess for both of you, that's fascinating. Does Dartmouth have practices, affiliated practices? Does Cincinnati? How do you affiliate?
I guess I'll start then. I'm still learning, and I had to buy a new car for this job. I had the same car for 16 years at Yale. I drove it, a couple of miles each day to the office, but now I have great distances to go. So I can tell you that there are Dartmouth Health sites throughout New Hampshire, and even a few in Vermont, or as far north as St. Johnsbury. And these sites, it's different relationships. Some of them are the doctors from here that are going out. Some of them are doctors that are employed in different ways and aligned. I'm still learning how that works. I'll tell you that from my experience, the best relationships are when you have very close, fiduciary relationships with physicians, and they're aligned with your practice, because That's where you can have the most influence on practice patterns, on the operations. It's too soon for me to tell, but the good news is we're out there, and so the way I look at it is, you can't run before you walk. So you have to get out there in the community, build trust. We did our fundraising events. We had an event in southern New Hampshire. Southern New Hampshire is a very important area for us because that's getting closer to Boston and Connecticut. And I want to have our practices in those areas. So it's growing. And it's too soon for me to tell you the overall strategy here, but I can tell you that it's definitely on the radar and it's going to be important.
It would be fascinating. David, how is your structure? How is the structure of your relationship with?
I think that's true for us as well. And I think that, the 2 points are, the first one is we have satellites, right? And we have cooperative agreements with other oncology groups, and it presents the opportunity to expand our reach and expand our ability to do clinical trials and provide precision cancer care for the community. But the other is the opportunity to partner with others, which is something I'm sure we're both exploring, right? And I agree with Roy when he mentioned this, that we should be thinking about working with other institutions, other cancer centers, right? Here in Cincinnati, we have 3 or 4 cancer centers that are within a drive distance. And I think that, not just our cancer center and our reach, but working with the other cancer centers close to us and working with them to build networks and to open clinical trials at more than one institution. I think all those things kind of play into the idea. If you want to increase your total number of clinical trials and like every cancer center, our cancer center also struggles, trying to put patients on trial, trying to convince build trust with the community. But we are also interested in him, but much like Roy, I've only been here, I'm week 4.
Yeah. It's, you have to learn and you have to listen. I've seen a lot of relationships for, partnering with centers. They all work, they all don't work. You might not have a hospital in that area. So what happens when the patient gets sick? You might not have radiation. One thing that I'm pretty impressed in here, we do have the radiation, in some of these centers. So that's a backbone. But you might not have the surgery. So you have to sort of build what you can. But I will tell you, putting clinical trials out does cost money. You're going to have a research nurse. You're going to have some special. It's easier to recruit clinical trials if you have specialty oncologists and hematologists, specialty radiation oncologists. So these are things that we're gonna grow, and we'll do it slowly. You also have to build trust. People have to know that they can trust your trials. That if the shingle is up there, Dartmouth Health, it's a quality product. High press Gini scores. People have a good experience. So these are all things that I'm going to go out there. I'm going to meet. I have a big team here. I'm going to enable my team. One thing I learned from Yale is, we did this as a group. The many people. I served 3 directors over 15 years, and we built things, and it took time. So I'm not going to be impatient. I'm going to make sure we have support and encouragement. But I am committed to getting trials to patients where they live, getting them profiled. That was the whole lung map philosophy. Get people profiled. What good is all the work we've done in EGFR lung cancer if we don't screen for it? So we're going to make sure that that gets done here in my catchment area.
Yeah, and I agree with that. If a cancer center is going to be successful in all the different aspects it needs to be, it's a team sport, right? And building teams and trusting your staff, right? The community outreach group and education. I agree. It's the stronger the team, the more that the cancer center as a whole can empower the staff, the more likely we are to accomplish the mission that the NCI is designated us to do.
To quote Joe Simone, leadership does matter. Right.
Yeah, I was fortunate to know Joe Simone when I was at MD Anderson. John Mendelsohn brought him down to help me and be a consultant and work with me in the clinical trials group we were setting up. And I used to have him in my office once a month. It was great. But you've just got to inspire and build a team. I want people to say, have I thought about this clinical trial? Do I have something better to do for this patient? And it does take time. Takes more time to put someone on trial. And people are, physicians are stressed. You hear about the RVU, and are we meeting our margins? So there is some pressure right now. So we sort of have to very delicately sort of show people the mission, inspire, and then just make sure they're supported as best they can for doing it.
Yeah, I agree. And I will say as well, Joe Simone is really an icon that we all look up to. And actually, Joe was born about 8 blocks from where I lived in Chicago. We're both from a Chicago Italian kind of neighborhood. And he's really one of the fathers of cancer centers. But I agree, right? It's really important to get out into community, right? And we want to, we not just get out, but to the community, but we want them to know that our cancer center provides superlative care. And we want the community to know that part of our job is to provide hope, right? And guidance for these patients who have, a diagnosis that's a difficult one. So I think, as I was saying, right, there's the 2 tracks, right? We need to provide superlative care, right? And the community needs to trust us, to come to us when they have the most aggressive kind of cancers. And then there's the academic mission, right? The cancer center and the clinical trials and all these things we do. And I think doing both of those tracks at the same time and trying to do them well, I think that's really key as I start my new position.
Right. And then, of course, there's, the early phase trials. And I'm a big proponent of decentralized trials where you can, do some of the, and you can even do a hybrid model where you can, you can screen the patients at a more remote site and then bring them back to the main house for their trial. Or certainly, as we're talking about, bringing trials to where patients live and is important too. And then, I do think there's a trust issue still with trials. Patients, need to feel that they can trust us. That's the whole basis of the WIN program in clinical trials that we've been working on for many years. We have to teach people how to do trials. There's a group out in Vail right now, doing that ASCO AACR course. I was a student in that, 1996, the very first one. But we need trials like that, but we also need to teach issues in the community and how to do trials in the community. And I think that's something that, I'm going to try to impart here as well.
Well, we should definitely cover that as you do that, because we're also trying to figure out how to even cover the kind of the convergence, what I think is a convergence of community and academic oncology. It's extraordinarily difficult. It's been completely a failure on our part to cover it thoroughly enough. But actually, I have another question on this is an absolutely insane story that we're writing right now. It's now become possible to bet on the outcomes of clinical trials and even FDA approvals of drugs. What are your thoughts on this? Are you writing letters to your staff and faculty to tell them to stay the heck away from this?
I haven't heard about this, but isn't that what drug companies have been doing for many years?
It is, but let's say you're an investigator on a clinical trial, and maybe you're even putting patients on trial. There's such a thing as equipoise, I would think, but should be. I don't know. This is me
that sounds pretty
speaking.
absurd to me. I think I'd stay away from that. But look, there's if every pharma is from the earliest phase to the phase 3 is trying to. I'm sure they have internal metrics for technical success and how things will go forward. And certainly, as an investigator, you use your nose to pick which drugs and which things to study. But betting on this, that's something I haven't heard of. That sounds pretty ridiculous to me.
Yeah, I have not heard about that as well, and I don't even honestly I don't know how to reply to this. But I will say this, right? That all of our staff, and I'm sure this is true at Dartmouth and every other cancer center, we have conflict of interest guidelines and courses that we take each year. And I would like to think, right, that if something like that occurred, that the staff would go back to their training and understand what a conflict is and what a conflict of interest is and how important it is for academics to stay on the right side of conflicts.
Mm-hmm. Oh, absolutely. I mean, what do you say to a patient? I'm betting on the outcome of this trial.
Well, you have to have equipoise. Look, there was just a trial that closed. I was sad to see this, a lung trial that was looking, I don't know if you saw this, David, the neoadjuvant versus adjuvant trial with immunotherapy. And because physicians didn't have equipoise, the surgeons felt that neoadjuvant was better. So that's something that's picking the right trial and making sure you have equipoise. But you have to take those biases out of things when you're doing these randomized trials.
Yeah, I agree.
Yeah.
And I know we've talked about this, and I don't want to, beat it to the death, but that's another opportunity, right, for us to do digital oncology, health sciences, and teams, right? So we do a better job of picking the right trials to move forward. But of course, I mean, some trials, Roy's right, some trials are not going to accrue. And there are probably over the years trials that could have been successful that we missed because we couldn't put patients on.
Yeah, they aren't using AI. I actually have a group coming by this week that wants to sell us a platform of using AI to sort of match patients to trial. We did some of that. Yeah, that can help only so much. You have to have the right data to input, but certainly it at least in an unbiased way, it gives you a list so that when someone shows up in your clinic, either the practice nurse, the research nurse has a list and puts it in front of you. These are the trials that this patient might be eligible for. I'm all for that type of help. And then, of course, being fair and telling the patients the risks and benefits. But look, the trials of today are the therapies of tomorrow. When someone asked me this, how were your last days at Yale? I saw all my patients, that I could because I knew I wouldn't be, I'm without privileges for a while. And they might not come all the way up north. And there are people who were on trials 10, 12 years ago on immunotherapy who are now alive. And I'm sure you have the same experience, David, with some of the things you've done. It's important to get people on trial because it can help them. And that's the message I would get out. And all this other stuff, just be fair, be balanced, and honest.
Yeah, I think I know who's coming to see you, which AI group.
You sent them my way, huh?
I did not, but I know who they are. It's please tell John I said hello. So, but I have another thought here. Whom are you trying to recruit right now? What kind of specialties? What are you beefing up? In case you're somebody's watching who wants to come and work for you.
So one of our initiatives, and I know this will be close to Roy's heart, is we're trying to build models for adaptive or acquired resistance to the current therapies, right? Targeted therapies, because we know they're going to happen, right? And what are we going to offer these patients when they put them on a targeted therapy like EGFR, right? And we know they'll fail. And we're really investing in mechanisms underlying the failures of targeted therapy. So, and then pushing those new targets into drug discovery, municipal chemistry. So we're trying to prepare ourselves for what we think the next cohort of patients will be. And some of those will be patients that just fail the target therapy that we're putting into the clinic this year.
That is very exciting. So I have actually over 10 physician scientist spots that I'm very eager to recruit with 40% or more protected time. You can even combine some of those packages to make it 80. So I'm looking to try to build physician scientists. One of the things we did at Yale, and actually when Charlie Fuchs was our director, he really pushed for a physician scientist program. And I think as I leave there, I think it's one of the best things, having physicians of all disciplines who are lab-based. I think that really helps to build the translation. So I was very fortunate. I have those spots here I have some space, so I'm actively looking for physician scientists. In fact, I'm meeting with our strategy team later today to do that. I also want to build up, Dartmouth has such a history of developmental therapeutics. I have Mark Ernstoff here from the NCI, who I've known for years. He retired from the NCI and he's here building the cell therapy program. But I need someone who's going to be an early phase investigator to really lead that program. And so I'm about to put an ad out for that. And, you always need great clinicians, but then I'm going to make sure I retain everyone that's here and build an environment where they want to stay. But we are recruiting, we actually also have, it's small, but each of our departments, foundational departments, has a slot a year or two and we are recruiting. So even at a time when many of the academic institutions are slowing down, we've been recruiting here. So send me emails. I'm happy to talk to people, and we're going to grow. We have to grow our science, and we have to grow our clinical care.
Yeah, and I think that's true here at Cincinnati as well. Right? And I also agree. Physician scientists are important because they kind of bridge that gap, right, between the basic scientists and the clinicians. And if you're going to pipeline drugs and do bench to bedside, right, and move your bench discoveries, drug discoveries in the clinic, those physician scientists are really important. They're important mediators, right, of making the sum greater than the parts for a cancer center.
Yeah, I couldn't agree more, David. And then grow your own. One thing I know, we didn't talk a lot about this, the Certec, but there's a lot of great programs going on. We have great undergraduate campus. I see the undergraduates and actually high school students in the hall here, through programs that we have. We fund some of this with our philanthropy to bring people into the labs. But I'd love to see more short tracking residents and more MD PhDs and more growing people through the fellowship. So these things take time. It's already happening, but I'm going to try to do more of this as time goes on.
Mm-hmm, mm-hmm. I guess, what would be the most hopeful thing you can say right now? What would you think is the most life-affirming thing to say right now, both to patients and to your colleagues?
I guess I would say that precision cancer medicine, has made tremendous successes and advancements over the last 5 or 10 years. And I really believe that the next 5 or 10 years, it's going to accelerate even faster. The personalized or precision medicine, I think right now is still groups of patients. But I don't think it will be very long when it really will be finding new therapies for specific patients through sequencing, next generation desequencing, through RNA-seq and transcriptomics, through metabolomics. I think it's the way that we are going to identify our patients in the future, both for clinical trials and for therapy. I think that has happened in a significant way in the last 5 or 10 years, and I think over the next decade, it's really going to accelerate through universities, cancer centers, pharma, industry.
I agree. The Cancer Center has a unique role here. I work in lung cancer. 30 years ago, no one would want to work in the field. Metastatic disease, it was horrible. Now we're using targeted therapy and immunotherapy in the earliest stages of disease. Some of the results with the Adura study for EGFR. We're about to present 8-year survival, which looks pretty good. I can't discuss it yet, but we'll present it at the World Lung Conference. But precision medicine, targeted therapy, immunotherapy, combined with, we still need the surgical and the radiation oncology and the good medical oncology, chemotherapy, but we have to pull it all together. We need care that's both personalized in terms of compassion and access, but also in terms of molecular markers. And we're doing that, but we're still just touching the surface. And, one of the things that, as we're talking about, we need to make sure our catchment area has access. What good is all this molecular profiling if 20% of patients don't get screened or they don't make it to the center? So that's going to be the challenge, taking things to the next level. I'm struck, David, by immunotherapy. It's amazing. We both do lung cancer. 10, 15% of patients are cured. But what about the other 85%, who's either have some activity and then become resistant, or those that don't respond at all? So we're not done yet. And we have to keep being innovative. And we can't just do trial A or B. We've got to do smart trials with markers, trials with mechanistic studies. So I think that's our goal as directors, to try to lead our centers in those ways, bring people together, fund the effort, inspire the team. But the bottom line is it's about the patient. I've been impacted. I'm on the board of the Friends of Cancer Research and worked with Ellen Siegel for many years. And I actually added her to my board here. I hope she'll come. And the idea is it's about the patient. We've got to be patient-centered and patient-focused, and that's really the goal.
Yeah, I agree. Patient-centered care is a very important part of, I think, where we're moving forward.
Mm-hmm. Mm-hmm. Well, thank you, Dr. Gius, and thank you, Dr. Herbst, and also thank you to our sponsor of the directors, ASCO. Hope to see you all soon. And
I appreciate the chance to chat with you. I appreciate the chance to be on a pod with Roy, someone who I watched many years and always admired his research and his work. And I can tell you, it's a real pleasure to be on with Roy.
Yeah, I feel the same about you, David, and I'd like to give you a call. We can share some of our experience and expertise as we do this. And I look forward to seeing you at some of the meetings that we'll be at together. So that'll be great.
I'm looking forward to that too.